the third question. Who among us did a blood test in last 6 months? I did, because I am diabetic now. I had a blood test. Your report? Name. You remember the name, ma'am? Exactly. This is where it comes to. So they are choosing ortho because they are having money, they are having an establishment, and they are having recognition. And we are doing what? Some surgeon is sending me a specimen and signing it out, right? Diagnosing and signing it out. Man doesn't know he's hematologist. Do you think anybody will ever remember us? Huh? So for ourselves, we need to start collecting specimens by ourselves. This is as a professional. What inference will you draw? It's about from a collection of tree, or it can be from a forest. So most of the times you see the requisition sheet that they send, they will write down patient's name, patient's father's name, mother-in-law's name, and there is the matter. And it becomes a quiz contest for the pathologist now. So, from the point of view of science, what is the science of diagnosis? I have a clinical presentation for a particular area, right? And then I'll cut it down, then I'll have a para-operative observation, whether it bleeds, whether it cuts easily, whether it is friable, and then how it heals after 7 days. And then we see the microscopic experience, how it is, how the tissue is. Now if you don't do the first two things and you receive a specimen, so you are giving a diagnosis, and that is why most of the time you will see a diagnosis of what? Odontogenic cyst. Have anybody read anything like that? Any identity in Cephal's book? But many a time you see it's a odontogenic cyst. So from the point of view of science, we need to go, which one? Do and collect the specimen by ourselves, right? Now number 3, while we were conducting this workshop, somebody asked me, are you handing over any hard material to read? And what we will discuss today, we will not discuss anything that is not known to me or not known to you. What we will discuss today is our BDS knowledge that is seen in the light of our MDS knowledge. Right? Like what? When you collect specimen, we need to know the anatomy. Now who will tell me the nerve supply or the blood supply of tongue? That becomes a little dicey. Okay, a patient is having aspirin. What will he do? All these things we have read in our BDS things. Agreed, everybody? So today's lecture we will not discuss anything like that we don't understand. All of you remember that dialogue from that movie? What is that movie? Famous South Indian movie? Part 1, Part 2? No, not KG. Hurry? Bahubali. Huh? That you have seen that warrior coming? Nimba, Amba. He was telling. We'll not discuss anything like that. So we'll gradually go forward. So this is me, this is our team that keeps on disturbing me, and this is the fantastic department that we have built up. And why biopsy? So over biopsy there are two things. One is collection of specimen, transportation of and preservation of the specimen, and number 3, processing the specimen. So today we will discuss all practical points on collection of specimen. I have only 30 minutes left. So let's go on. When do we do a biopsy? Anybody? For a curious look, anybody has done a biopsy? Parental pockets. So when we have disease, that will fail to explain. We need to correlate a certain clinical expression with its microscopic process. Then diagnosis a disease. Means hyperkeratinization. Many a times I see in clinical sign out results hyperkeratinization. That can happen in oral lichen planus, that can happen in OPMDs and plenty of other dermatosis. Can it be a sign out diagnosis, ma'am? Clinical diagnosis? No. And then he will write everything from submarine to septipine, use this mouthwash, use this paste, and it's all like a blind dark system. So this is exactly why a hyperkeratosis case should be referred to an oral pathologist. So I exactly know where to cut, how to find out the specimen, and then corroborate those findings in my microscopic findings. Then monitoring disease progression. I'll take one question. This will be an interactive session predominantly. Sardarji, you are from which college, sir? PG faculty? PG. Actually, can you tell which year? Second year. How can you diagnose that a oral lichen planus has healed? Clinically? Okay, what are the diagnostic features?
The lesion is getting small in size. Yes, we say that it is healing.
Any other?
Pigmentation is same brownish.
Brownish pigmentation. Ma'am, in a active lesion, can I have a brownish pigmentation? Why do we have brownish pigmentation, ma'am? Huh? Huh? I'm not getting your point, ma'am. Can you? Always remember, oral lichen planus, this hyperkeratinization, even in an inactive disease, will stay. Because it will take very long period. What is the active state and the inactive state? The PM and the lymphocytic infiltration. So by seeing clinically, can I say that the lichen planus has healed or it is active? We can't. We can't. Go back today, and why I say that we should, I'll give you an exact example. See the histological features of oral lichen planus and discoid lupus erythematosus. So somebody has sent you a specimen, you have cut it down, and then you give a features, histologic features that can apply to lichen planus and some discoid lupus erythematosus. So what diagnosis do I give? It's a complete confused state. So then you have to do ANF and double-stranded DNA test. If it becomes positive, that is a discoid. If it is negative, that is a LP. Right? So you cannot deal a LP case purely from a specimen. So this is the confirming abnormal findings. 15 days ago, I don't know whether we have that slide or not, a completely ulcerated pigmented lesion. And cost me 22 years, I have been dealing with these biopsies and all those things. That lesion, we have never seen. So that was absolutely an abnormal findings. Then we went through the slide, multiple sections, and it came out to be a pigmented oral lichen planus. And absolutely rare lesions. My PGs, you have seen that case? Yeah. So these are the reasons why scientifically you should always claim a biopsy. Or at least, if you are not confident enough, you should be confident enough. You are not confident enough, you should be present during the biopsy. Otherwise, merely giving a tissue diagnosis is a misnomer. Now, when you say that, immediately somebody will tell you, and what about the general pathologists? They are never called in oral. Do we have any subject like general medicine and radiology? But we have a oral medicine and radiology club subject. Why? So I'll give you an example. Right now we are sitting over here. All of a sudden you heard a huge explosion. Right? The same explosion happens outside the Lal Killa, that metro station. And the same explosion is happening on a Diwali night. Our reactions will be different. So any subject of medicine is applied on temporal variation, means when it is happening, where it is happening, and spatial variations. So oral pathology, if we want to have a maxillofacial diagnosis, you need to have me in the clinical. So, I'm going up back. So what is biopsy? These are the things all of us know very quickly. So in today's course, what I intend you to do, number one, we will discuss in very short the theory part, because anatomy you have to go back home and read a little pharmacology. Aja, how many of you know whether a person with cirrhosis of liver, can I give paracetamol? It's a very safe drug. Who will tell me? All of us, we write paracetamols, PCMs. Can we give? Then what do we do? Ma'am, every day we write paracetamols. What do we do, ma'am? Anybody? No clue? So we add something known as N-acetylcysteine, and there is a brand Paracetamol. So that protects. Paracetamol, remember, is mainly metabolized in the liver. Right? So a cirrhotic patient already have altered liver function. So these are the things you need to apply. So you can't have rights, you have duties. So every day you have to read oral pathology as such, anatomy of head and neck, physiology, general medicine. We will see. I will mention the salient points there. So essentially it's a surgical removal of tissue. They are essential while we have talked about. So even today biopsy is the gold standard. Even today biopsy is the gold standard. What are the techniques? Incisional and excisional. Where we will do incisional? Anybody? Where the mouth opening is very less.
So when the lesion is very big.
Where the lesion is very big and we don't know what it is. Okay? And anything else? Exactly. When you suspect, there is a malignancy. Okay? So all these things. So these are this is the main criteria. All of us remember. A person walks in with any lesion and you immediately jump into diagnosis is not the norm. So wait for 2 weeks. 2 weeks from when? When the patient observed or I observed. 2 weeks from when? Are you getting my question? So we have to wait 2 weeks. These are all American Medical Association recommendation. 2 weeks from what? Huh? We see, right? Because the patient can't see inside the mouth. Normally you can have reflected vision, but the patient can't see inside the mouth. So 2 weeks from the first report. Now suppose Sarah's seen 2 weeks before there is an ulceration on the lateral. I can take that. He's a qualified medical practitioner, dental practitioner. He has given a report. but some qualified medical person should have observed it at least 2 weeks before. Ulceration, induration and unexplained bleeding. Display color or texture changes. Can anybody say when this happens? This is an interesting case. Color changes and very important too. Color changes when we see, sir? Huh? Granular? Not exactly, huh? Leukoplakia is a color change, but texture change, exactly. I want a different answer. Yeah, and nevus is there. And nevus is there since birth. Agreed, everybody? Now all of a sudden, somebody has come to Ghaziabad for this conference, and in 7 days' time, he or she goes back and sees the melanoma changing color, started bleeding, increasing in size. Then you don't have to wait for 2 weeks. You can immediately jump into the biopsy. This is a long-standing nevus that can show 4 things. One is increase in size, change in color, ulceration, or become painful or symptomatic. Then I don't have to wait for 2 weeks. Rapid growth or surface irregularity, and in high risk areas such as lateral border of tongue, floor of the mouth, or soft palate. Oh, this one I need to explain. Request histopathological confirmation. When do we need? A person has come to change a denture. Okay? He is not known for any oral, he doesn't have any other oral symptoms. It's all, he has simply walked into a clinic for a change of denture. And while removing that denture, in the buccal flange area, you see a ulceration. So you don't have to wait for 2 weeks. We don't have to wait for 2 weeks. Immediately you can go for a biopsy. So incisional biopsy, primarily it's diagnostic than rather. Now I'll give you an example. In one area, in Calcutta there is a big field, Brigade Parade Ground, that can fit 10 lakh people. And we know 100 terrorists has entered into that 10 lakh people. Agreed, everybody? Now how do I diagnose? I take samples from northern side of the field, from southern side of the field, from western side of the field. So basically I am doing a statistical sampling. I do a statistical sampling. And in Faridabad there is a house where there are 10 people and you are suspecting something is wrong over there. So you simply nab all the 10 people. Don't take my examples politically. It's just, I don't have anything against anybody. It's just to make you understand. So we immediately catch hold of the 10 people. Now what's the basic idea? Why the approach is different? Because I can't catch hold of 10 lakh people. Brigade Parade. During communist we were in West Bengal, we were in communist reign for a very long period of time. And they used to arrange fantastic rallies, 15 lakh people, 20 lakh people, like from South Carolina. They will go to the meeting. So I can't catch hold of all of them. So essentially now you see, incisional biopsies are statistical sampling. So even after removal or doing a biopsy, there is a high chance that some terrorist will stay back in that crowd. So the disease is left back. But in case of Faridabad case, I have not all 10 of them. Maybe 8 of them may be innocent. But I have. Okay. So essentially, excisional biopsies is a diagnostic process and at the same time is a treatment process. Whereas incisional biopsies Because of my inefficiency to deal with that huge sample, it's basically a diagnostic process, and subsequently I have to come back for a more definitive treatment. Agreed, everybody? So we'll go through them a little fast. So when large or diffuse lesion more than 1 centimeter. Now this 1 centimeter, I don't know how we are, somebody says 2 centimeter, somebody says 1 centimeter. Now that depends on the location of the lesion. How? A 2 centimeter lesion on the buccal mucosa. Yes, jolly well we can easily remove them. A 1 centimeter lesion on the soft palate. On the posterior part of the soft palate. Can we remove them that easily? So, it depends on the availability of your infrastructure and expertise and on the location of the lesion. Right? Again, a hyperkeratotic lesion, 2 centimeter, 3 centimeter in the buccal mucosa, in the commissure. We can just remove it like that. A vascular lesion, 0.5 centimeter in the below the roots of the first molar in maxilla. Will I do that with the pulsating? So, again it depends on the anatomic location and the infrastructure I have. Ulcerative, indurated, infiltrative lesions, these are all features of, clinical features of malignancy. Lesions located in areas where complete excision, as I was telling, complete excision would not be possible. Advantages: preserves lesions for further management and allows histopathological diagnosis prior to definitive. We had a fantastic case, right? A person reported with a small traumatic ulcer. And naive happy as we are, in Calcutta everybody is very naive happy in the dental colleges. So we excised the whole lesion. And we thought it's a simple either traumatic or syphilitic ulcer or tubercle ulcer. Then it came out there are some superficial invasions, nothing else. Then we went for a ISC, and what Subhalakshmi find out, there is a complete invasion of the connective tissue. Now you see, we have removed the whole lesion without keeping anything. And we learn from our mistakes. So where from, our oncosurgeon will see where the lesion was. Luckily the sutures were retained. So that is the area from where we have collected. Immediately we have to add a wide excision with SO in the supramoid dissection. What are the limitations? It's a sampling and we need a second process. We need a secondary process. These parts will go. Excisional biopsy, as I told, is a therapeutic as well as diagnostic. Indications: small lesions, benign innocuous papillomas, odontogenic fibromas, all these things we will, pyogenic granulomas. What about pregnancy tumors? Ma'am? Excisional, incisional? Huh? Excisional. How many of us are in favor of excisional? Sir? Huh? No need of any biopsy. Thank you. Wait for the pregnancy to be over. Most of the time it will subside of its own. So, total removal, this is very important. What we weigh, if we remove the total thing, there is high chance, the potential of risk is very low. Over here, one thing we should remember. If you are dealing with a melanotic, any form, I am not talking about melanoma, try always to go for a excisional biopsies. Whenever you are dealing with a pigmented lesion, other than absolutely where you know it's a plumbism, where you have a silver impregnation, always try to go for an excisional biopsy. Advantages, same as I told, I will not repeat the same thing. Limitations, not appropriate for large, a suspicious lesion, where clear margins cannot be guaranteed. Many times what happened, you remove additions, people are getting bored and they are yawning. They remove the lesion as a ulcerated pyogenic granuloma, and then you find out it is some form of exophytic malignancy. Then you land up into a... So always, if you are sure that you can have a rule is, I can have a safe margin, I'll go for a excisional biopsy. What information do we get pre and post-operatively? This is exactly the scientific reason why we should do a biopsy. What exactly? These are the 4 points. Visual and tactile. So, has anybody cut a hyperkeratotic lesion and seen after cutting it? None of you? Huh? So how hyperkeratotic lesions appears, man? Hyperkeratotic. Whitish. As soon as you remove it, you can't find out. That's the magic. Because keratin is white only in presence of water. Keratin is white only in presence of water. So you cut it, then you dry it, you will see the hyperkeratotic lesion is gone from the cut sample. So until and unless I have a clinical note, you only merely seeing the patient won't serve any purpose. You have to keep a complete clinical note. There are 8 photographs in case of lesions that you need to take: floor of the mouth, tongue, palate, both the buccal mucosa, both the lips, upper vestibule and lower vestibule. These are to be taken. See, when you are claiming something, you have to have a record keeping section, because most of the time, at least it will need 3 to 4 days for you to come back to the diagnosis, right? Under the microscope, and then you need to refer to those photographs because you are removing the lesion. So visual and tactile. What are the visual and tactile things? Abnormal color, texture, consistency. Anybody has felt the margin of a malignancy? Have you felt the margin of a malignancy? None of you feel it. Malignancies, they have a typical feel, they have a typical appearance, and trust me, they have a typical odor too. If it is a large oral malignancies and the patient enters your clinic, from the smell only you can make out there is a malignant ulcer. Because, why? The microbial flora changes in the malignant part. So it has got a typical, I was trained in Haryana. Luckily we had, unfortunately we had huge amount of, malignant patients. In a year when I passed out, we did 1258 biopsies, only on malignant. Forget about other cases. So it has got a typical appearance, it has got a typical feel and a typical odor. Anything else? Any other features? Clinical features? Judawal? Matted lymph node. Most of the time, not matted. Palpable, found to have immobile lymph nodes. Anything else? Again, I will give you a hint. Please, this is a take-home message. If you do the biopsy and the patient comes back in 7 days' time, a frank, ulcerated, exophytic malignancy, most of the time, when he or she comes back, you can't find the biopsy site. what happens? It immediately fills up. If you do a small biopsy, a punch biopsy or an excision, I will show you some biopsies. You will see, in 7 days time, it immediately fills up. The growth is so high. This is a cardinal feature, we will see. This is a cardinal feature of a malignancy. So, if I have removed some tissue and in 7 days time, I see the whole thing has come back, this is a cardinal. Even microscopically, if it is benign, go back to the sample, go for routine sections, Ripple sections, and I'm sure in most of the or in all of the cases, if this is the clinical finding, you will get a malignancy at some point. So found and irregular, infiltrative, then unexpected or incidental finding. We'll have a case. Fantastic. You'll see, it's a older lady, 70, 72, we'll show you that case. 72 years old. She came back for an ulcerated lesion on the front part. So that happened to be that came out to be a verrucous carcinoma. Now what causes verrucous carcinoma, sir? What causes verrucous carcinoma? Tobacco. What causes squamous cell carcinoma? Tobacco. The same factor that causes verrucous carcinoma causes squamous cell carcinoma. So it's a spectrum. It's a spectrum of genetic change. But the patient actually reported for the verrucous carcinoma. We have that case. And then while doing that biopsy, I saw another growth on the posterior lateral part of the tongue, and I took the biopsy. That came out to be a squamous cell carcinoma. Which one I should treat first? The squamous cell carcinoma. Right? So this is how it helps when you are there to collect the biopsy. So these are the unexpected incidental findings. Additional lymph node, like she said, hemorrhage or vascular involvement. If I go with the histological features of a pyogenic granuloma, and if I challenge you, note this is not a pyogenic granuloma, this is a capillary hemangioma. It's all the same. Only post-operative bleeding, history of post-operative bleeding can confirm whether this is a pyogenic granuloma or a capillary hemangioma. And lastly, the tissue response to manipulation after that the thing I told about in 7 days time. Very quickly we will go forward. Specimen handling I will skip. This all of you know. Just 2 things. Never put a specimen. Most of the time the general surgeons will do that. They'll collect the specimen, directly they will throw it in a formalin jar. So what happens? Hemoglobin pigmentations will happen and all your diagnosis will be at jeopardy. A second surgeon will do what? He will collect the specimen, keep it, throw it on side, and he will be more concentrating on the arrest of hemorrhage, then closing the wound, and the tissue will dry out. So don't allow the tissue to dry. Neither you have placed the tissue in formalin with the hemoglobin pigmentation, for the hemoglobin pigmentation. These are the armamentariums. These are routines, basic instruments, aspiration syringe for local anesthesia. Okay, BP handle blades, all of us we know. Very quickly, dissecting scissors. Most of the time we use the IDs dissecting scissors. These are fantastic scissors that you can dissect out. We'll see dissecting. Why we need a dissecting scissor? Anybody? For undermining the surrounding. You have taken a collected a specimen. punched a hole in the oral mucosa. Now we need to undermine it so that we can extend the oral mucosa in the surroundings. Artery forceps, all of us know, this is the standard and this is how we maintain it in our college. Or in our college, all instruments are supplied from a central CSSD, Central Sterile Supply Department. You can see them all pouched. For heart tissues, we need a periosteal elevator, mostly Howard's. Then gel foam, anybody knows what gel foam is? Abgel. The commercial abgel for hemostasis, surgical valve, and beep. Why beep? So the dead space is not, you have scooped out a piece of bone from the mandible, so there will have collection of blood. So we fill that space with gel foam. These are the hemostasis and retractions. Electrocautery these days are normal. So this part I am going a little fast. Okay. Now, case history. Then this is now we are dealing with the patient. Never forget these days to take a informed consent. And if the patient is below 9 years, the consent should be from a accompanying adult. And always mention the relationship. So often our written consent, investigations, we'll come back to this. So basic, full blood count, then we have bleeding time, clotting time and INR. Everybody is well versed with INR? Huh? What is that? Essentially?
International normalization.
Now what is that? Prothrombin time. It's a comparison of the prothrombin time. Then blood sugar, medicine, most of the time you ask, are you diabetic? Patient will say no. And then you see his blood sugar is 110, fasting blood sugar. But what he will never tell you, this 110 fasting blood sugar is with the metformin. He thinks he's a controlled diabetic, but he will never explain tell to you that I'm a diabetic. So advice like means antibiotics. For all, we'll see the preferred antibiotic is these days is amoxiclav, 2 grams 1 hour before the procedure. 2 grams of amoxiclav. In case somebody is hypersensitive or has known allergic, we can use clindamycin for oral. Analgesics, all of you practice? Huh? For an extraction, when do we give the analgesic? दांत निकाल लिया, अब गया पेशेंट बाहर बैठा 10 मिनट, फिर आप लिखा गिव केटरॉल, घर जाके एक केटरॉल खा लेना और जेरोडॉल पी खा लेना, राइट? एंड देन द पेशेंट कॉल्स यू बैक, कैसा दर्द हो रहा है, isn't it? पर दवाई खाने से कम हो गया. Always try the analgesic. You give the local anesthesia. How long it stays? A local anesthesia, standard nerve block. How long? 30 minutes. 30 to 40 minutes. Give the NSAID during that time. What will happen? By the time local anesthesia wears off, the NSAID will take its effect. And the patient will never have a painful episode. What are antifibrinolytics? Pause. Tranexamic acid. Again, it takes 25 to 30 minutes. So you cut a hole, then the patient waits 20 minutes in your waiting area, and or you extract a teeth, then goes back to his home, God knows where it is, and then he or she settles down, take the pause for the antifibrinolytic. No! Give the local anesthesia, let the patient have the antifibrinolytic. Mild sedative we routinely use in our hospital. Always remember, in dental situations, any dental situation, patient do have a component of anxiety. So, who can say what is an absolute contraindication of a biopsy in emergency cases? Why you can't perform a biopsy? Huh? Anybody from this side? Not from this side. Anybody from this side? Absolute not. You can't do a biopsy. Dr. Rakshit will definitely disagree with me these days. Anybody? Sir, आपको? नहीं, आप कैमरा ले लें. For all other cases, we can take a biopsy. For any other cases, we can take a biopsy. Only thing is we need to modify the process. Anybody, uncontrolled diabetes, radiotherapy patient, will see how we do it. So some special cases, we know India has become the diabetic capital. So any idea what should be the fasting blood sugar, random blood sugar, HbA1c? Anybody, sir? So random blood sugar should be 200, 130 is the fasting blood, 180 is the PTBS. These are not my guidelines, these are American Heart Association guidelines. And HbA1c 7.5%. So that you are absolutely safe. You are absolutely safe, nothing will happen. Now who will tell me why diabetics are more prone to develop infection? Ladies from this, high glucose level, how it helps, sir? No, sir, it's not blood agar or blood. Immunity. Diabetics, remember, diabetics are not more prone to infection. Even uncontrolled diabetics are not prone to develop infection. Once infection sets in, they can't handle with it. Once infection sets in, they can't control it. Why? Because the liver is in negative nitrogen balance. From all protein sources, liver is producing glucose via neoglucogenesis. So we have very little amount of globulins. So no immunoglobulins, no humoral immunity, and they are more prone, once infection sets in, they can't handle it. But diabetics, controlled diabetics, if you have a proper preoperative antibiotic and then continue it for another 5 days, even I am telling you, fasting blood sugar as high as 160 won't harm you. Or HbA1c 8.5%, you can safely do a biopsy. Hypertensive patients, now who will tell me what is the BP till which we can do? Sir? 140? By 90. Whose recommendation? These days, whenever, see, when we talk to patients, you are doing it before taking a biopsy. No? So, actually, in all European countries, you have to mention, see, we can do a biopsy provided your HbA1c is less than 7.5, as mentioned in this journal. We are lucky that we don't have to practice in that way. So, whose recommendation is that? I'll go a little fast. 180 by 110. 180 by 110. This again is the AHA recommendation. This again is the AHA recommendation. Now a frank malignant patient walks in. He knows that he has some ulcer. He can have a malignancy. And that morning he had a bad fight with his wife. So he drops into your clinic with a BP of 220 and 110. Will you turn him down? What do we do, sir? Very simple. There are short-acting antihypertensive, nifedipine. Give an anxiolytic, let him forget about his wife, so that he comes back, a fresh man in half an hour's, 1 hour's time, And now you will see with dipping, these days we have fantastic nitrodipping nasal drops. They come as small soft capsules. Give it to them and you will see the pressure dropping down in 10 minutes, 9 to 10 minutes time. Give a repeat in another 30 to 40 minutes. Another special case, okay, diabetic hypertension, irradiated patients. Many a times what happens, a patient had a malignancy, he got operated, he underwent radiotherapy, and then he comes back with a recurrence. So, the NHU where you cannot work is 3 weeks, or where we will do a biopsy. Within 3 weeks, we see another growth, right? Or a nodular mucosal indurations, or fast enlarging growth is there. Normally, you are safe to operate in 10 to 12 weeks time of the completion of the radiation. Will you extract a tooth in 10 to 12 weeks time? Why? You can't extract a tooth, but you can do a biopsy. Huh? You can't extract a tooth, but can you do a biopsy? Biopsies are soft tissue mostly. You can't do a hard tissue biopsy. You can't encroach the bone. But soft tissues, vascularity increases very rapidly. Within 3 months, so 10 to 12 weeks, you can actually do a biopsy after completion of the. And urgent biopsies, suppose in days to weeks time somebody's ulceration is growing, then you don't have an option. You can go for a biopsy. Only thing is, I will show you a punch biopsy instead of a widespread incisional or excisional biopsy. Cancer chemotherapy. So, in cancer, many a times they come with the recurrence with cancer chemotherapy. So the absolute neutrophil count, this is not a differential count. Absolute neutrophil count should be more than 1000. The platelet count should be around 1 lakh, and the hemoglobin percentage should be 8 to 9 grams per deciliter. And the best time is 3 to 5 days before the next chemotherapeutic cycle. Chemotherapies, they are given in cycles. So before the next chemotherapy cycles, 3 to 5 days before that. Why 5 days? It will epithelize in 5 to 7 days time. So before the next chemotherapeutic cycle, 3 to 5 days, take a small biopsy. We will not get into the pre-surgical. These are the checklist. Okay. Okay. This is important. What is an elliptical or a wedge set? Can anybody tell me? What is elliptical wedge set of an incisional design? If you see the mucosa from top, it should be elliptical. And if you see the mucosa in cross section, it should be wedge shaped. Means the upper part will be wider, while the deeper part will be narrower. The upper part will be wider and the deeper part will be narrower. Now this elliptical incision should be in such a way that it has a normal mucosa, the border of the lesion and the body of the lesion. It has a normal mucosa, we'll see multiple elliptical, the body of the lesion and the boundary of the lesion and the body of the lesion. And why wedge shaped? Anybody got any idea? Suturing will be actually easy, Rakshit, if we give a reverse wedge, as we do to close down gingival incisions. So why do we need a wedge? এরমে তো হবে normal tissue নিলাম এরম কেন? Why this is the outside, this is the inside. And in hemostasis, suppose you cut like this, here you puncture a vessel, you can't even see that, and then you close down, a huge hematoma forms. If it is like this, you can see the whole wall, and any vessel you have ruptured, you can actually repair it down, right? Undermining margin, as I said, the margin should be, you will see undermining in one palatal cases. I've selected some portions from various and suturing of margins. So this is the first case. Is it moving, Subha? So we are spraying, see the palate, you can see the, can I stop it for once? So here is the lesion. Can anybody explain the lesion? An erosive area or an ulcerated area on the lateral part of the palate. Now comes our clinical consideration. What are the things that is possible? Now whenever you do a lesion like this, always think what are the host tissues present in normal. So what are the host tissues present? Epithelium, agreed? A periosteum, the bone, anything else? Look at the lesion. Anything else will be there? Greater palatine vessels, much mesially placed. Anything else? See, this is where our knowledge will come into action. Most of our palatal minor salivary glands are located on the posterior lateral part. So, these are the things we will pathologists. See, we can't have normally until and unless it is metastatic, a kidney tumor in the tongue. So, any neoplasm or anything will be related to an epithelium, the submucosa, the minor salivary glands, or the bone, and that's all. And vascularity, the greater palatine vessels. So now you will see, we will give an elliptical incision. This is, we are spraying it down. We will give the local anesthesia. And then you see, this is not a typical local anesthesia. This is the case we are taking to the hospital. And then we have the elliptical incision. And we see the direction of the blood. Great. We are creating a wedge. Now we are striping the periosteum off because the mucosa is tightly bound to the underlying periosteum. And now you see, we are creating, we are undermining it. We can't use a scissor in this case. We have to do a periosteum so that we can close it off. Now. And now suturing. Always keep a white grip because if it is an absorbable suture, you have the freedom to move from right to left, top to bottom. So always keep a 3-0 for palate or thick mucosa, 40 for skin mucosa. And with absorbable suture, you can give it a continuous suture. We are actually giving a continuous closure. And now you see, we have completely closed down the wound. You can't even make out from where we have taken the mucosa. Okay, we move on to the third case. Yeah, this is another fantastic case. This is tongue, lateral border of the tongue. We haven't cut anything and we are giving a suture. What it is? That is not from this part of the We haven't cut anything and we are giving a suture. No. If you see two things. Tongue is the madman of the mouth. So you ask him not to move a feeble bridge. He will definitely, he's sitting there, you are crossing the feeble bridge, and you ask him, hey, I'm crossing, don't move that bridge, or I'll fall down. He will definitely do that. Right? So in Bengali we call it pagla ke shaku narate parona. You ask the patient, pull out your tongue. Try it sometimes in your clinic. Tongue on for the time being. So this is one. And number two, the vascularity of the finger, I don't know. See, whatever you read in Gray's Anatomy, that is again a statistical finding. Means the artery will run from year to year. No, the artery can run from year to year in 0.5% cases. You never know whether this patient is 0.5% among that 0.5%. Similarly, tongue, the dorsal lingual artery will run on the dorsal part of the tongue from the hyoglossus and come in front to the tip. But you never know, it can move 1 inch to the right, and then you give an incisional biopsy and you make a bullseye. Now the dorsal lingual artery is bleeding. So what we do? We give a suture at first, a silk suture, and catch hold of the mad bull. So now the tongue is under your control, and at the same time, you do a bullseye. All you need to do is to tie the silk, so the bleeding will stop. So every time you are actually doing something on the tongue, lateral border of the tongue, first give a 2-0 silk suture. Where from I learned all this thing is nothing is given in love and myth. It's DIY. In Aram and Dental College, 10 years seniors, they used to do that and got fantastic results. We follow, and 10 years down the line, they are still following. So this is how it works. So see, you will see indurated ulceroproliferative mass on the right side of the tongue. Yeah. Now we are giving the suture. See, it's a deep suture. And we don't tie it. We ask you to hold it. Now, we have given a lingual block, but tongue is a vascular organism. So you have to give local infiltration. You have to give local infiltration away from the lesion. So the vascularity is reduced. Now you see the elliptical incision creating a wedge. An elliptical incision creating a wedge. Can you make the elliptical incision? Make out the elliptical incision. And now this, if you are not that confident, you can dissect it out with a scissor. Since I do only these things, I cut it with a BP handle plate. Any bleeding happens, I manage it. But initially you can. Now, one of my PGs were not happy. Sir, we are not having enough bleeding. And then we enlarge the lesion. Now see. Actually this happened. One of my PGs was, sir, we are not seeing enough bleeding. No problem. So I took a second. You see? See the topmost level now? Exactly, that is why I took a second. Now suturing technique, we will be giving a vertical mattress suture so that the tongue is completely closed. Now you see the portion of the we do it day in, day out in our hospital and clinic. And only this is how you can actually place an impact locally among your patient. You will have a patient bank. And even the surgeons will have a lot of praise for you. Why? In this case, I will refer to some surgeon. Now I am the controlling authority. Instead of the surgeon being the controlling authority sending me a specimen, I will send this patient to some surgeon. So I will pick up his phone as I wish. Closer. And if you extend it properly in the oral cavity, any amount of gapping wound you can actually close. You will see this was such a huge gapping wound. Now see this case. Which case is this? Oh, I'm going on top. Yeah. This was the case we were talking about. This is not in our hospital. I visit another hospital where I was doing this. She had a history of a malignancy of the floor of the mouth 8 years before this date. Subsequently, he reported to my clinic. Now you see there are two growths. Can you make out? There are two growths. So same thing, I'm taking hold of the tongue. This video was made because we were projecting it at some other conference, right? So it's not enough. Now you can make out two different growths. Patient came for the fast growth. So we will have basically একটা সিঙ্গেল টিস্যু, যাতে যে প্যাথোলজিস্ট পুরো বুঝতে পারে কোনো পাঞ্চ নয় কিছু নয়, See, now I am taking the normal tissue. Always, if you are confident, always prefer a incisional biopsy by a BP and plate. They works a wonder. This is the Alice, so that I am not hurting the tissue. And this you should, at least to start with, you should do it with a scissor, dissecting scissor. Do you see any pain in that lady's eyes? No pain as such. Chalo. Okay, this is another case. So this is the last case. So tongue we can do, all of us. Huh? So this is gingiva, now see. Here, any flap, it should be designed in such a way that the base is always wider and the apex should be always narrower. You apply some basic principles and it works a wonder. Now you see, oh, sorry. So it's a gingival lesion. Well, we had some punches. Can all of you make out the lesion? Easily available in our dental clinic. This lesion has actually caused bodily movement of the two teeth, lower midline diastema. Again, this you can do with a periosteum, but I am confident with scalpel belt. Can you see the teeth moving? So the lamina dura is all taken up by the lesion. The bone, you can now see the bone. Okay. And we'll advance the flap and close it. Okay, now. Sir, I am not confident in doing all those things. I need some time to get trained. So will I not collect? So there is a fantastic instrument they have brought. For all of you, we have carried that instrument from Calcutta so that you can have a exposure on it. It's called a punch. So in that punch, all you need to do is to place it vertically on the lesion. Is to place it vertically on the lesion, then give a clockwise direction. The cutting edge is in the lip of the lesion, that is known as a punch. Place it inside, give a cross-sectional, and then don't pull it out. Just ease it out in an anti-clockwise motion. you will have a cylinder of tissue. Okay? And then hold it with an alice, cut it, bring it out. Right? It's an absolutely simple process. Only disadvantage is if a patient is on an anticoagulant, then these are, see, cylindrical tissues, they are vertical walls. So don't give a suture immediately. Wait for a while to achieve the hemostasis. Wait for a while. Pack it with a glove, with a gauze, wet gauze, so that hemostasis is achieved. Otherwise, you can at times land up with some hematoma. At least, will anybody tell me a person is taking 75 grams or milligrams of aspirin? What you will do? Do a biopsy? No? 75 milligrams of aspirin. Huh? How many days should I stop? 3 to 4 days? Anybody has got any other brilliant ideas? 2007 American Heart Association recommendation says you don't need to stop aspirin if it is till 150 milligram. By doing that, what happened? You predispose that patient to a cerebrovascular accident or a coronary accident. 75 grams, 150 grams, you don't need to stop. Please go back today. All of us, we have cell phones. Check out 2007 recommendation, American Heart Association. It's an 18 years recommendation. We still don't know. And what happens if it is a clopidogrel? How many days? How it works? This is the thing. See, I told you it's all basically undergraduate knowledge in the light of postgraduate training. Why? How aspirin clopidogrel works? What happens? How bleeding stops? Very quickly. These are the things we need to know. Primary platelet plaque, how it happens? Instead of the platelets. So if the platelets are defective, they won't form a primary platelet. This is why bleeding time will increase, while the clotting time will remain essentially same. So all my platelets need to be healthy and the unhealthy platelets need to be replaced. So what is the turnover time for platelets? What is the turnover time for platelets? 7 to 10 days, sir. So if you are actually stopping anticoagulant, please stop it for 7 days. Otherwise, you are just doing a placebo. If it is clopidogrel or aspirin 300 milligrams, don't stop it like that. Go for an INR, international normalized ratio. If it is above 2.5 times, patients have to give them the chickens, not to eat. Oh, for the demonstration. Okay. So stop it for 7 to 10 days. Until and unless you stop it for 7 to 10 days, it hardly has got any effect. When will you start? On the 10th day, if I have stopped it, so wait for 3 days and start on that. So on the 10th day, I should start. So these are the simple things which we keep in mind. And now, in this, you will not see the lesion, but see the turn of the punch. Oh, because I am holding it. Yeah. So I am giving a normal inferior alveolar block, and it is in the vestibule. Now see the movement of the lesion. I have placed it in vertically And now I am rotating it, doing nothing. And you can see the tissue coming up with the punch. Fantastic. Now you see another. This is a thing all of us should have. In fact, in last year's PG convention, this was the gift. Punch, set of punch, 3 millimeter, 5 millimeter. Now you see, we are just bringing it. See the other side, you can see more. Yeah. Now see, vertically I am pressing it. Gone inside, buccal mucosa, the whole thing, and now just gradually ease it out. Can you see a cylinder of tissue? You have the punch, na? And see the Alice is there. Cut it. Do it with the scissor. So done. Any questions? We stop over here. Clear? Most of the things? Huh?
So term biopsy, there are some complications post of
Yeah. What are the post-op complications of a tooth extraction? Number one, pain. It will be there. Even says hemorrhage. Tooth extraction hemorrhage occurs. In biopsy, hemorrhage occurs less than tooth extraction. Not even 1%. Number three, swelling. A swelling will be there. Yes, it will swell more than a tooth extraction. Means why? Because this is a soft tissue, more vascularized. Number four, there can be hematoma. Hematoma can happen even in a tooth extraction. Even a mobile tooth extraction, if you suture it very tightly, many times we tend to suture it very tightly, the next day patient comes back, especially not patient of my complexion, but fair complexion patients, they will come out with a huge hematoma of the chin. In my complexion, there is no problem. So all these things, and number five, you can have a nerve paresthesia. So do you extract the teeth in your clinic? You can do a biopsy.
so the nerve, glossopharyngeal nerve and lingual nerve which passes on the tongue in both the third. So patient can have loss of taste sensation and some if he injured.
Ma'am, I sincerely ask everybody, this is not, taste sensation of the tongue is from chorda tympani, a branch of facial. It has got nothing to do with the lingual nerve. Lingual nerve, anterior two-third is from, supplies the general sensation. Lingual nerve comes out of the vertical higher plexus muscle, goes into the mass of the tongue. So you can't damage a lingual nerve like that until and unless you do something where the mandibular nerve bifurcates into an inferior alveolar and the lingual in the lingular region. Once it gets into the floor of the mouth, you can't damage it. So biopsy tongue, biopsy buccal mucosa, biopsy lips are absolutely fantastic to do.
So punch can be used in tongue also.
Yeah, punch can be used in tongue. And once you are an expert, just one thing, remember a few things. If you have sterilized your instrument well, you can't have an infection that will endanger your patient's life. Number two, if you are not operating on you and you hate your eggs and operating on her, you can't possibly land up into a bleeding situation that will endanger his or her life. All oral bleedings you can actually stop with a pressure pack. And trust me, once in a while we do land up into a situation where the patient is profusely bleeding, like a fire alarm going on. Then what do? They call me, sir, it's bleeding. Fantastic, I'm coming. I sit in the ground floor, they are in the second floor. I go there and then I keep talking to them and hold it tight. And with my body weight, any artery will collapse. So they collapse. All you need to do is a pipe. These two walls should meet each other. For how long? 3 minutes. Once they meet each other for 3 minutes, you go and have a cup of coffee. Nothing will happen. So, my only aim of doing this course is you people should start doing more and more biopsies. Nothing happens. It's easier than heart tooth extraction or placing an implant. There are no complications. And once you do that, you are in the commanding position. Okay, these 30 cases I do biopsies. So 30 cases you have generated in your clinic. And then you call a max fax surgeon. I have 30 cases. Any day at the middle of the night he will come to you with a burger and pizza. 30 cases you have supplied. Remember one thing. Merely academic success works fantastic. But it's good to have a commercial success. It's good to have a successful practice. And once you do these biopsies with Sir, I'm done. Will stay. So once you are having a good biopsy, they will come back to you to do a root canal, to do a denture. Which? So there are 3, 5 and 7 centimeters. Normally we go for 5 centimeter branches. If it is inaccessible, go for 3 centimeter. And if you want a large, like buccal mucosa, you can go. So we are going, so very quickly, please. Heart palate we do, ma'am, but not near the artery. Try not to do it in a artery. Means along the course of the greater palatal artery. But we do heart. In that case, you can't close it because it's a round A. You plan a cover plate before that. Okay, chalo. So, I'll do a biopsy. You will see. We will be given a chicken piece, not to eat.